Hi everyone, I'm Ed Highland. Welcome back to the Big Ideas Theater here at AARC. We're talking about ventilator-induced lung injury. We're talking about it with, once again, Neil Ross McIntyre. Thank you so much. Duke University, well represented today.
Thank you, Ed. Thanks. Good. It's good to be back again. Ventilator-induced lung injury is one of my favorite topics because I think it's a place where the respiratory care team can really have some impact in the ICU. We went for probably half a century with ventilator settings that seemed logical in the operating room, but translating that into ICU care was not as simple as people thought it was going to be. It turns out that when we do exceed pressures, normal distending pressures in the lung, when we exceed normal tidal volume stretch in the lung, when we don't properly manage the collapse and reopening injury, we can cause significant harm to our patients. And a ton of research over the last probably 2 decades has really shifted our whole thinking about how to manage people on ventilators. We used to, as I say, worship at the altar of the blood gas, and we've come to learn that the price you pay for super blood gases may really be excessive because of the stretch and strain injury on the lung. And I'm pleased that we're slowly but surely finding the world is coming around to these what we call safe ventilator settings.
Well, give us some thoughts, if you would, on what can be done to prevent or minimize the injury.
People kid me, but I feel like Moses. I have 3 commandments. Commandment number 1, thou shalt not exceed a transpulmonary pressure of 30 centimeters of water. That's commandment number 1. Commandment number 2, thou shalt not exceed a tidal volume of 8 mLs per kilogram. And commandment number 3, thou shalt use a rational PEEP FiO2 algorithm to manage our patients. And like I said, there have been surveys done around the world that have slowly but surely indicated that the world is beginning to follow the commandments.
I was going to say, so these are commandments. In other words, you can't bend these?
You can't bend these.
No, you don't bend commandments.
You don't bend. I mean, we're being a bit glib. There are sometimes extenuating circumstances, of course, but for the vast majority of people, the commandments are commandments.
Give us some thoughts, if you would. Is the practice, is it changing to address the issues and this understanding?
Yeah, so one of my favorite studies came out a couple of years ago. It's called the Lung Safe Study. And it was a huge survey of ventilator practices around the world. Thousands of patients were in it. And the good news is, commandment number 1, keeping the max transpulmonary pressure, which we often estimate by the so-called plateau pressure, keeping it down below 30, the world is doing that. The vast majority of patients in the Lung Safe Study were not being exposed to maximal pressures more than that. That's the good news. Tidal volume was not quite as good. The majority of patients were being ventilated with tidal volumes less than 8 mLs per kilogram, but there was a significant minority that were not. Now, as you pointed out astutely, there are always exceptions, but this was more than just, oddball exceptions. There's still a lot of education to be done around the world in getting those tidal volumes further down. I think the most disappointing result of the Lung Safe Study was the PEEP FiO2 exposure. And it's sort of interesting because the PEEP used in all of these, or most of these trials, usually on average range between 10 and 15 centimeters of water. And the Lung Safe Study showed that around the world, the vast majority of patients are being exposed to PEEPs less than 12. The world is still afraid of PEEP, which I think is a challenge for us. And the price the world is paying for, if you'll pardon the expression, under-PEEPing, is a very unnecessary FiO2 exposure. This survey showed that exposures to FiO2s above 60% was very common around the world. So, like I said, there's good news and there's bad news. but as a lot of people like to say, with bad news comes opportunity. So one of the reasons I love coming to this meeting is it gives us an opportunity to get people rethinking how they do things. We're making progress, but we're not there yet.
Is the technology helping? Is it to a point? I mean, you've been doing this a year or two. Can you give us some thoughts on because one thing I hear, and again,
Yeah.
I'm a layperson, but one thing I hear is that sometimes there's so much technology. You're almost an information overload, and you got to monitor all of this.
Ed, you are spot on with that one. The manufacturers have, I'm going to give them some high marks and I'm going to give them some not so high marks. The manufacturers, I think, have been very helpful in trying to educate and provide machines that are easy to use to meet these three goals, these three commandments. So they get gold stars for that one. They have been reluctant to do a couple of things that I think they could. Number one, I mentioned a moment ago, the plateau pressure. Plateau pressure is a surrogate for the maximal transpulmonary pressure, because it's usually done at end inspiration. No machine will allow any kind of automated plateau pressure measurement. A therapist actually go in and push a button to make it happen. This is not a difficult thing to do. It only takes half a second. It only needs one breath over an hour, 30 minutes, whatever your interval you want. It's a very, very simple addition to put on the ventilator, and it gives you a wealth of information on maximal stretch, as we've already talked about, but it also gives us additional information on lung mechanics that I think can be very helpful. And I cannot get the manufacturers to provide an automated measurement for this. So maybe this big idea theater can be a little propaganda to them.
Or there's a little idea that can have a big impact. How's that?
I agree. I think it can. I think it can.
And anything else on the technology side?
So the other part of the technology that I would love to see manufacturers get more involved with is what's called decision support. In other words, I'm not asking the ventilator to automatically provide settings, but instead have the ventilator monitor what the clinician has put there and give them, for lack of a better term, advice. You know, Mr. and Miss Respiratory Therapist, I think you might reconsider that setting. So decision support, using standard algorithms, evidence-based protocols to inform the clinician that they are on the right track or maybe not on the right track.
It's a little backup. I mean, it's you know, somebody's kind of looking over your shoulder. You sure you want to do that? It makes you think twice about it.
Yeah, it's got a buddy.
Yeah.
There next to you who happens to have the evidence base in front of them, who can kind of help you along. I think this is a real opportunity for industry to get more involved. And I know they get nervous. They say they don't want to practice medicine. I get that. I get that. But I'm not asking them to make the adjustments. I'm asking them to advise the clinician on what might be a legitimate.
There's been great strides in artificial intelligence, so let's put some of that to use.
Let's put some real intelligence to use.
Exactly.
I agree. I agree.
Neil, thank you so much, as always, coming by and sharing the latest and greatest.
Ed, it's always fun to talk to you.
And this is the Big Ideas Theater at AARC. I'm Ed Highland. Thanks for joining us.